Hello, everyone. My name is Sinsel Mazidi, and I'm an assistant registrar at Al Batain Center for Burns and Plastic Surgery. And today I will be your host for today's session. I will be introducing a new series at Surge Kuwait. The new series, as you've seen before, it's CME accredited. And we're happy to start our new series called ABCs of Research, which is given by our beloved Dr. Sara Lioha. This is the first session of a 4-session course. The first session, as you can see, is about critical appraisal. And as you've seen earlier in the video, there are further sessions as follows. And without further ado, I would like to introduce our speaker, Dr. Sara Lioha. She's a board-certified plastic and reconstructive surgeon from Canada, and she's currently working at Jaber Al Ahmed Hospital. Welcome with us, Dr. Sara.
Thank you so much, Dr. Sindis, for this great introduction, and thank you so much to the wonderful team at Surge Kuwait for all the hard work and the wonderful efforts. You've put together multiple amazing programs, and I think you've kept us all sustained during the pandemic. So it's just been wonderful to work with all of you, and I'm really honored that you asked me to give this talk. I guess it's going to be a series of talks. Like Dr. Sindis said, there's going to be CME points involved. So if you attend all the talks, I think it's 12 points that are category 1, which is equivalent to live attendance. So that's great.
So Dr. Sara, just a reminder for everyone that if you have any questions, please feel free to ask them in the Q&A panel. And please don't forget to register for the next sessions and the Surge Kuwait sessions as well. And refer to the link, as I said earlier, in the chat as well. Dr. Sara, the mic is yours.
Thank you. The focus of this first talk is going to be introductory. So we thought we'd start with some questions, like our usual Surge Kuwait format, just to get you guys going. So I think, Dr. Ali, we're going to share the questions right now in the poll.
They're up on the screen.
Perfect. So the first question is, the goal of a critical appraisal should be to A, determine where fault exists in the study design, B, evaluate whether a proposed study is feasible, C, identify the meaning and credibility of a study, and D, review the credentials and expertise of the researcher. So have a few seconds to choose one of those.
Um, 10 seconds left. Ending the poll now. And the results?
Okay, great. I think most of you got the correct answer. That's great. Okay, can do the next one, I guess. So when critically appraising a research study, the reviewer will expect to find A, identification of a new research problem, B, implementation of a perfect research design, C, precise understanding of the real world, or D, tools to control outcomes in clinical practice. So again, you have a minute.
$30 seconds left. Ten seconds. Ending the poll now. And the results are?
Great. So I guess this one was a little bit trickier, but again, I think most of you, 36% of you had the right answer, so that's great. And I guess moving on to the last question. So how can healthcare professionals participate in critical appraisal of research? Is it by A, adhering to evidence-based guidelines and best practices? B, by presenting findings from their own outcome research? C, by questioning the quality, credibility, and meaning of studies? Or is it by D, reading research journals to keep current in knowledge and practice?
30 more seconds. Ten seconds left. Ending the poll, and the results are as follows on the screen. Dr. Sarah, you go ahead with the lecture.
Okay, great. Okay, so is there a lag? Okay, so this is the outline of today. It's gonna be busy and there's a lot of information. It's not gonna be as interactive in this session. It's gonna be more didactic. If you have any questions, I think midway we can open the chat and you guys can throw them at me at any point. We'll start by introduction to evidence-based medicine. Then we'll just talk about basic things regarding research design, because this critical appraisal portion of the course is just going to focus on critiquing research design, not the statistical part, which will be the focus of session 2. We'll talk about finding a suitable research design for your question. How do you select study subjects, allocate them, the data collection process, measuring outcomes, and then a systematic approach you can adopt to critical appraisal. And then finally, how do you apply evidence-based medicine in practice? So I'm warning you, this is not like giving a surgical talk with, it's not as exciting, but it's very, very important for all of us in terms of how we should conduct ourselves clinically. So like we mentioned before, these are the other talks that we'll cover. So these topics won't be covered today. So just to start you off, what is evidence-based medicine and why is it important? So evidence-based medicine in a nutshell is a method by which we can apply our collective wisdom as a group to an individual problem. Okay? Basically, you know, not everyone knows everything and we might be biased. So evidence-based method is just tools that give you mathematical estimates of benefits and harm from research on populations, basically to inform our decisions about individuals. And we base most of that on research, and all research it's just a focused, systematic inquiry that enables us to generate new knowledge. And these research questions can vary, as you know, from looking at symptoms, diagnosis, prognosis, therapy, economic analyses, and patient preferences. And there's multiple steps in this, and you know, this has been touted by multiple articles in the BMJ, and McMaster University in Canada has been spearheading a lot of the efforts in evidence-based medicine, but it's basically one of 5 steps. The first step, which is foundational and very important, is basically when you have a problem, how do you convert it into an answerable question rather than an open question? The second part is going to be how do you track down the best evidence to answer those questions? Critical appraisal, which we'll focus on today, is basically appraising evidence critically to assess its validity and how useful it is, basically how clinically applicable is information we're reading. Then we're going to be looking at applications. So how do you apply the results of this appraisal to your clinical practice and integrating it with your clinical judgment? And then the last step is monitoring. So it's a process of continuously evaluating our performance to look for areas of improvement. So really, this is a cycle that should be going on endlessly. So as critical appraisal is the basis of evidence-based practice, they're really essential skills. And some people have said that critical appraisal skills are new stethoscope. So it's important to identify important research and learn how you can apply it to your practice. So the aim of this process is to be systematic. So having a fixed system where you're going to assess the validity of the study and how relevant it is to your clinical practice. And you can see on the diagram that it's a multi-step process. And overall, our main aim of critical appraisal is to assess the validity of research and statistical techniques by answering two major questions, okay? Does the research have internal validity and does it have external validity? So internal validity is to what extent does the study measure what it set out to measure, okay? Are the methodology that the study used robust and do they match the question? External validity is to what extent can the results from the study be generalized to a wider population? So can I apply these to my patient group specifically? Do the patients in the study have similar characteristics? So to address this and to go through the critical appraisal process, I'm gonna go through 6 points, which is basically what are the elements of research design? That's what we're gonna start off talking about. And then we're gonna talk about how to apply it, okay? So there's 6 parts to this. We're gonna talk about assessing what is the question in research and how do you frame it? What is design? How did the patients get sampled? How did the patients get allocated to different groups? What are the outcomes of research and how are the outcomes measured? And we'll go through each of these in detail. So first one we're gonna look at is framing your question. So questions when you're critically appraising research should be directly relevant to the problem at hand. So your aim is to create a question so that it directs the search to relevant and very precise answers. So, you know, broad questions such as, how do I treat diabetes? That doesn't work. You get too many results when you're searching the literature. Those questions are what we call background questions. So for instance, if you're a medical student and you first started to study a subject, your questions are going to be very vague and open. And that's where you're going to go to textbooks and maybe narrative reviews. But when you're asking foreground questions, you have to be very specific. And what's recommended is that you use the PICO framework. And I'm going to keep on repeating the PICO framework because every time you read a paper, every time you design a research study, the first question I want you to ask yourself, it's what's the PICO, okay? And just write it down on a piece of paper. So PICO, I'm sure most of you know it, but it's basically a very simple acronym. P is for patient or the problem. So basically you write down that description. I is for the intervention. So you describe the main exposure, test, prognostic factor that you're looking at. C is what's your comparison? What's your control group? You're comparing A to B, so what's the comparison? Not all research studies have comparisons. For example, if you're looking at case series, but it's worth thinking about. And lastly, O is our outcome. So what are we hoping to achieve? What's the effect we're measuring? So here's an example, and I don't know if we can open the chat because this will follow with a question that people can answer in the chat box, but basically, a patient presents to you with acute appendicitis. The patient is reluctant to undergo surgery and wonders whether there are any other treatment options. And recently you read an article that antibiotics may be an effective therapy. So you decide to carry out a search of the medical literature using the PICO search strategy, and you come up with this paper in the New England Journal of Medicine that was recently published, an RCT comparing antibiotics with appendectomy for appendicitis. I'm sure you may have covered it at one of your journal clubs. So my first question is, in the chat, can you write what you think the P is for the study, just by quickly looking at the methods? I don't know if the chat is open yet. And if you can do the PICO, what's the P, what's the I, what's the C, what's the O? Okay. So the P for this one is going to be adult patients with acute appendicitis at 25 US centers. The I is going to be antibiotic therapy for 10 days. The C is going to be appendectomy. And the O is basically they have 30-day health status as assessed by some sort of questionnaire. So you can see that as soon as you read the abstract in a paper, you can immediately just make a small table and write down the PICO, and it will immediately frame your mind to what are the next things you should be looking at when you're critically appraising. And research questions fall into 5 fundamental types of questions. So we're either looking at therapies, which is what the previous study was looking at, to look at a drug or a treatment and its impact on an outcome. We may be looking at harm, so determining the effects of potentially harmful agents on outcomes as well. There are differential diagnosis studies, so for a new disease entity, establishing the frequency of certain signs and symptoms. Diagnostic studies, which look at power of a test to differentiate between it and what's called a gold standard treatment. So how good a CT scan at picking up acute appendicitis, for example. And then there's prognostic studies. So looking at risk factors and seeing how they impact a patient's future course. So why is that important? Well, it's important because when we frame our PICO question and we decide what sort of a research question it is, we want to know what is the best design for that question. So the next question you're asking yourself, does the design fit the question, basically? And why is this important? Why do we need to match a study to a specific research design? Basically, if you use the wrong design for the wrong question, then it doesn't really work. So for example, if you look for a randomized trial to inform you of the properties of a diagnostics test, you just won't find the answers you seek. And that's one of the first things we use to determine internal validity. So each of the 5 main types of clinical questions have study designs that are a best fit for them, and I'll just go through them briefly. So the first category we talked about was therapeutic studies, and obviously the best match for those are RCTs. Very often you'll find that people do observational studies for these, such as case control, and the most common thing I've seen is retrospective cohorts, which is fine, but it's not the ideal study design, and we'll talk about why later. So this is an example. So this is, for example, the article regarding the Pfizer vaccine to look at its efficacy. And since this is a treatment, if you're not sure what the research design, you just go to the method. So here they'll just mention this is a multinational placebo-controlled basically trial. So this is a treatment and they use the RCT. So this is appropriate research design. And that's the first question you'd ask yourself. Here's another example where they looked at NSAIDs and saw if it's associated with a higher mortality in COVID. And you can see again, if you're not sure what the study design is, you can just briefly look at the abstract and it will tell you that this is a retrospective observational cohort study, which means it didn't make it to the New England Journal of Medicine because it's less impactful as a research design to answer that question. So RCTs have multiple types, and we touched upon that briefly. So you can have RCTs that are uncontrolled. So all subjects are given the same treatment, which I don't think is as powerful. You can have controlled studies where you do have a placebo arm, and then you can have randomized and non-randomized controlled. And then you get designs that are fancier. So you have crossover studies where group A receives a treatment, group B receives another treatment, and then they switch over. And lastly, you have factorial design, where you have more than one intervention. So you get multiple people getting different types of treatment. And it's less common as a design. I think the most common is going to be, just your standard RCT that you'll see in most literature. So the second type of question is studies determining harm. And again, the best match for this is an RCT. The problem is RCTs are usually impractical for this because let's say you were going to study smoking, the effect on smoking on mortality. It's not ethical to give half the subjects cigarettes to smoke. So most of these studies tend to be observational, ideally a prospective cohort study. And referring to this is one of the most famous studies by Sir Richard Dole. So this was a prospective cohort study that took place from 1951 to 2001 to show that smoking was bad, basically, because at the time people didn't know it. So this was a 50-year observational study on British doctors. So it's a landmark study and appropriate design again. So there are other types of observational analytical studies. We talked a little bit about cohort studies, and cohort just means group. So if you say prospective cohort, you basically have a group of subjects in the present and you expose them to whatever and you match them to another group that don't have the exposure, and you just follow everyone up to see who gets the outcome. Retrospective cohorts are basically you identify a cohort that has already happened and you just add another outcome of interest to it. And I think this is very common in surgery. Case control studies, they look at the past and basically you identify subjects who have the outcome you're interested in, say mortality or a certain morbidity, and then you match them to subjects who are similar to them but don't have that outcome. And then you look at the past to see if they had a specific risk factor or not. So we look at examples of these. So an example of a case control study is this one. So risk factors for a second hip fracture in elderly patient, an age, sex, and fracture type matched case control study. So like you can see in the methodology, this is a retrospective study, and they identified a group and then a second group, a control group, to look at the specific outcome, which is a second hip fracture. So there is one more observational analytical study, which is a cross-sectional study. I usually see this one in surveys. So surveys are usually cross-sectional. And why is that? Because cross-sectional studies are the only ones that look at the present, so they're a snapshot in time. So you're looking at the prevalence of an exposure and outcome in a population at a specific point in time. This type of study cannot really establish causation because you're missing the time interval between an exposure and an outcome, but it just gives you the idea of prevalence of certain elements that you're interested in. So this is an example. So a cross-sectional study of the prevalence of dementia, basically in nursing homes in Austria and the Czech Republic. So you just study whatever you're interested in one time and you just report usually just frequencies and percentages. Okay, so the other type of study is a differential diagnosis study. So investigators collect a group of patients with a similar presentation. So you record the signs, symptoms, other elements, and then you test them to see what the actual diagnosis is. And this informs you of what signs and symptoms you should be looking for. So an example that's been recent is this one, which is real-time tracking of self-reported symptoms to predict potential COVID-19. So the time that the study came out, we didn't have a good sense of how COVID-19 would present. So in this study, they actually gave a phone application to 2.5 million people and asked them to record their symptoms and then tested them for SARS-CoV-2 and then determined what are the profiles of the signs and symptoms for those patients. Next one is diagnostic studies. So in the study, investigators identify a group of patients in whom they suspect a target condition. The patients have the new test, and then they have the gold standard test, and basically you're comparing the new test to the old test. And then you're able to classify patients to see how good your new test is. And again, this is sort of a prospective cohort. An example is a study I had the privilege of being involved in where we compared 3D printed swabs to commercial swabs for the diagnosis of SARS-CoV-2. You can see it's a pandemic, so all my examples are related to COVID-19. But basically, all that was done is that patients got swabbed with a 3D swab, then the commercial swab, and then compare that to that. So that's a classic design for that type of study. And then lastly, prognostic studies. So prognostic studies, you identify patients who belong to a specific group, like patients undergoing surgery. And then you basically look at how that modifies their prognosis, and you look at that over time. Okay. Again, this is a prospective cohort. And the example is the COVID Surge Collaborative, which I'm sure a lot of the audience members were involved in. So you're looking at surgical patients who had SARS-CoV-2 and looked at their outcomes after surgery, mortality, pulmonary complications, etc. So that's an appropriate design. And of course, there are other types of studies. You have descriptive studies like case reports and case series. Those are narrative, so you don't have a lot of analysis there. You have audits to look at service provision. You have surveys, economic analyses, qualitative studies, systematic reviews, and meta-analyses. And I don't think we can touch on all of them, but we'll talk about strategies to critically appraise those two briefly. So we talked about what the question is the design good? So the third part we're going to talk about is how did the patients get sampled, okay? How did we select the patients for our study? So basically, like we said, after stating a question and choosing the design, we'll next describe how did we recruit the patients and how did we allocate them into different groups. And so it's usually described in the method section. This is where a lot of studies fail. So any shortcuts, any poor technique to speed up recruitment, trying to find the easy out, is going to lead us to selection bias. So when you're critiquing a study, I think it's really good to focus on how were the subjects recruited, because this is where you're going to find a lot of research methodology errors. So, and what is the idea of sampling and how is it done? So researchers tend to identify a target population. So like in that previous study, let's say your target population is adults with acute appendicitis. It's not usually possible to recruit every single person in the target population. So we find ways to make that group smaller. So instead, you pick a sample that should be as representative of your target population as possible. And we define that population by the inclusion and exclusion criteria. So our goal is that the results from the sample will inform us and we can generalize it to our target population. So you can see on the right-hand side, this is the classic diagram that you will see in most papers where you have a flow diagram, the population, the sample, inclusion, exclusion, and what happened next. So just to give you a bit more detail, so inclusion criteria, they're basically your list of criteria which must be met by your target population to be included in your sample population. So this can be, you can say it's pediatric, adult patients in a specific hospital, in a specific country, et cetera, et cetera. Exclusion criteria are very important. So it's the list of criteria that if a subject meets, you're not going to allow them in your sample. So why might you even exclude someone? There are three main reasons why you would exclude someone. One is if the subject is too unwell to even take part of the study. For example, if you're looking at the Pfizer vaccine and you have patients who are severely immunosuppressed, it would be unethical to put them in your study because you might make them sick, okay? The second one is if the subject is at risk of becoming unwell during your study. So if a patient has potential allergies to your drug, then you should exclude them. And the third one, if you want to exclude a subject who has a specific confounding factor. For example, if your patients are over 80 and frail. So those patients, let's say if your patient is 90, 100 years old, well, they're very likely to die in the next few years. So if you're doing a mortality study over multiple years, it doesn't make sense to recruit those patients. Plus, they have so many comorbidities, your design is not clean, okay? However, just make a note of having too many exclusions can be concerning. One, practically speaking, they make recruitment harder, okay? If you end up with multiple exclusions, then your sample size just keeps on shrinking. The second issue is you might not be able to generalize your results from your samples to your target population. You know, if I am focusing my study on adult patients between the age of 18 to 30 who have no comorbidities and no issues, but my patients are actually sick patients in their 60s and multiple comorbidities, I can't translate this to that. So it's just something to bear in mind. You have to find a sweet balance between both extremes. And once you decide how you're going to define your population, how do you exclude them and include them, you might still have a big sample size. So you need to narrow it down further. And there's different methods of sampling, okay? Because let's say I'm going to look at adult patients with acute appendicitis in Kuwait. Okay, it's still too big. So what can I do? You'll have to pick a sampling strategy. So the easiest one is just to do random simple sampling. Easy, but not so easy actually, because it can be a challenge if your target population is huge. So in a random sampling, every person in the target population has an equal chance of being selected. It's like you just pick them out of a hat randomly. Okay, this is probably the best method. The second way is called systematic sampling. So you say every 10th, every 100th member of my target population is chosen. It's another strategy. The third way is called stratified sampling. So if, say, I wanted a specific ethnicity to be represented, and they've used this a lot in the vaccine trials where they said, okay, I think Moderna wanted a certain number of people who are ethnic minorities, like certain number of Black participants. You can say, okay, I'm gonna pick all those out and randomize them to make sure that both groups have an equal number. So that's what you do. You put people into subgroups and then you randomly draw from those groups. The fourth strategy we have listed here is cluster sampling. So what you do in cluster sampling is you divide your population like a piece of pie, and then you sample from those clusters. So an example would be, if I want to look at acute appendicitis outcomes in Kuwait, I can say, okay, let's divide it to the 5 or 6 health districts, Hawali, Asama, Ahmedi, and then I'm going to randomly pick from those groups. Okay, and that way you can make sure that all the areas are represented. And the last one, which is the most common one, is called convenience sampling. So convenience sampling is sampling that's done when people, they show up, you get recruited, okay? Caution, this is definitely the most common. The most frequent way I see this being done is I have a questionnaire, I'm just gonna send it to everyone on WhatsApp and see who responds, okay? It's easy, it's convenient, but it's the most risk of bias and confounding because automatically by using the strategy, you've narrowed down your group. I don't think it represents the target population. Now your sample represents your group of best friends. So I just be aware of that. And, we'll talk a little bit about bias and confounding because it's a really important concept. So just to show you an example, so in that paper we looked at in the New England Journal of Medicine, this is how they would list the inclusion and exclusion criteria. So in this study, they looked at consecutive English or Spanish-speaking adults over the age of 18 in the emergency department with appendicitis, and they confirmed it by specific methods. And then you can see on the right-hand side in their flow diagram, out of 8,168 patients, they included a whole bunch for many reasons. And they just list them here. So it was really important to have this diagram in your research and also to be very critical with it because, if half the population speak French and you excluded them, this is not a very good study design. It doesn't represent my population. So when you look at exclusion criteria, think about how applicable it will make the results later. So like I said earlier, we'll talk a little bit about confounding and bias, okay? And what is confounding? So As you see in the diagram, most clinical questions are looking at a relationship. We have the exposure and we have the outcome, and we want to know, is there a relationship between the two? So the confounder is basically something that can cause the outcome that the patient has, okay? So even if the relationship is proven, there might be other reasons why that relationship exists, and it could be confirmed by the existence of this third factor, okay? So an example of this is if I was looking at whether paracetamol causes hepatic injury, and my patient sample had a lot of alcoholics. So alcohol consumption can cause hepatic injury. So then, okay, so this is a confounder now that I need to be thinking about in my research design to minimize the effect. And confounders are not just positive confounders, which I just mentioned, which is, something that results in the association between the two variables that are not associated. You can also have a negative confounder. So a negative confounder is the opposite. There is an association, but it hides it. So the example I give here is if you're looking at the link between poor diet and coronary artery disease, if you don't account for exercise, then this can hide that effect. So your aim really as a critical appraiser is to identify your confounders and look at did the research design address them? And did they list them in the methods? Now, if you do have confounders, like, you have alcoholics in your samples, what do you do about it? Okay. So you can either eliminate the confounder altogether in your exclusion criteria. So in the case of paracetamol and alcohol consumption, you can say, I'm going to exclude everyone who uses alcohol regularly, for example. The second way is to nullify the effects of your confounder by spreading them out equally between different groups. And that's where randomization comes in. So you can say, okay, I have two groups and they have an equal number of alcoholics, so they cancel each other out. And the third technique that's employed commonly is account for their effect in the results and correcting for it using statistical technique. And you see that a lot in multivariable regression analysis. So it's a statistical means to account for that difference. We can talk about that in our statistical section. So this is an example of table 1. Okay, so the table 1 in most RCTs or most research studies, you're looking at specific characteristics, which is the confounders, so age, gender, body weight, certain comorbidities, and you can see that the treatment group has 30 patients and the placebo group has 25 patients. And this usually always has a p-value. So what you're looking for in table 1 is a p-value that's not significant, because you want to prove that the confounding factors in both groups are equally spaced, if that makes sense. So the number of diabetics is equal, so then you've nullified their effect. The second thing we want to talk about is bias. So we alluded to that earlier, but bias is basically when researchers recruit a sample population that doesn't represent the target population. So bias is really an issue with research design, versus confounding, which we talked about earlier, arises from a real-life relationship that already exists between the exposure and outcome under consideration. So bias leads to just the wrong results because the research design is not that good, whereas confounding leads to the wrong conclusion because I have good results. I'm just not sure if I can apply them because I have these other factors. And when you're looking at the research design, you're looking to identify, is there any selection bias for my sample? So I just put some examples of selection bias to give you an idea what you're looking for. So there's something called an admission rate bias. So when you take your sample from the hospital setting, for example, if I'm looking at COVID-19 severity in hospital, it's not really representative of the entire condition because you have asymptomatic people in the community with the condition, but you're not accounting for, okay? And you see that in a lot of the studies that look at therapies. The second thing is called the diagnostic purity bias. So when comorbidities are excessively excluded in a sample, like we said before, it doesn't quite reflect the complexity of cases in a population. So like we mentioned earlier, if most of your patients are elderly with multiple comorbidities, then, if you put a lot of exclusion criteria in your study design, then it's not going to work very well. You also have survival bias. You see this in conditions that are rapidly progressive, such as pancreatic cancer. So the problem with this, if you're looking at mortality for specific treatment, then patients with severe disease that die in a few weeks are usually not recruited to the study, and your study is biased because you're looking at the milder conditions. You have membership bias. So when you use the membership of a group, so let's say I'm going to look at cardiac risk factors in people with a gym membership, then you've already biased your selection because you're just looking at fit people. Next one is historical control bias, and you see this when people do studies over time. So when you choose your subjects and then your controls are from the past. So this is biased because treatments have changed over time. And the last one is response bias. So are the patients that are recruited to your study different from the population because they volunteered? Are they more enthusiastic, more likely to give you time commitments? Are they richer so they can actually come and get tested versus patients who are impoverished might not take part? So, things just to think about. So how do we reduce sampling bias? There's no perfect study, but you usually need a larger sample size. And the question is, how do you determine the ideal sample size? Because, do we just pick random numbers from the air, 1,000, 2,000, 3,000? How do we decide how big of a study is good enough that it will eliminate these flaws? So this all comes down to doing what's called a power calculation, okay? And the aim of this is to minimize the risk that the observed differences between your two groups are due to chance, okay? So you need a power calculation, which is a statistical tool, to ensure your sample size is correct. And you need to do this for any study design you're doing, okay? Not just RCTs. So what is power? Statistical power? It's the probability that a type 2 error will not be made in the study. Again, what does that mean? A type 2 error, the technical term is when the null hypothesis is false but is accepted. So just basically in English, it's basically the failure to discover a difference between two groups, okay? Lots of jargon, but it's basically failing to pick up a difference, okay? So it's a measure of the study's ability to detect the smallest possible difference between groups that is considered clinically worthwhile. We don't want a study that's too big because then it's a waste of money and it's not really ethical. And if it's too small, we're not going to pick up the difference we're looking for. Larger sample size means you have better power. Inadequate sample size we would call underpowered. And how do you do these calculations? You should be done at the start of the study. And you can use online calculators, or you can have a best friend that's a statistician and they can kindly do this for you, okay? And it's generally based on parameters using similar studies as a guide. So you have to find similar studies, use your clinical judgment, and then you can do it. So here's an example from that same article. So the randomized trial comparing antibiotics. And here's how they described it. So they said, under the assumption of this mean, using that questionnaire, we calculated that they needed 1,552 people to give sufficient power. Okay, if you're interested in all that jargon, we can talk about it more in the second part of this series. So part 4, so we talked about research question, research design, sampling. The fourth thing to think about is how did the subjects get allocated into the different groups? Okay, so allocating study subjects sometimes is, not well described, but the best way to allocate study subjects so that you're minimizing bias is through randomization. So randomization ensures that all the people entering your study have an equal chance of being allocated to either group. It's not the same as random sampling. So random sampling is recruitment, randomization is allocation, okay? And again, you have multiple methods of randomization. You have fixed methods, so you can do just a simple randomization. Again, just pulling names out of a hat. You can do block randomization, so you can say we're going to randomize instead of people, we're going to randomize patients in wards or different areas. And you can have stratified randomization. Again, you can stratify patients by ethnicity or age or whatever, and then randomize them. And commonly, you can also have an adaptive randomization method. So if you have certain targets in each study arm for what type of patients you want. So you see this in the vaccine studies, like I want a minimum of 20% of patients to be over the age of 60, then you can adjust your randomization to account for that using specific computer programs. Okay, so the next thing we're going to look at is what are the outcomes that this research design has. And this is really important. So data collection is something that I have a measure that I'm going to look at, and now I'm going to collect it in a specific way to be objective. So this is where the effects of expectation fall into play, okay? So expectation is going to impact the results. And to protect against our inherent biases as humans, we need to have blinding techniques, okay? So we need to have placebos, we need to have objective measures to avoid what's termed observation bias, okay? So what is observation bias? Okay, so an example of this is interviewer bias. So when a researcher is not blinded to the group allocations, the research might be a little bit skewed in how they record the results. So if I know that this patient is in the treatment arm, I might, be more generous with my scoring than if I thought they were placebo. So this is where blinding helps mitigate that. You also have response bias. So subjects who are in a study might answer the question or behave in a certain way because they believe that's how the researcher wants them to answer. And this is similar to a Hawthorne effect, where subjects alter their behavior when they're being observed. For example, if I want to look at the effect of a certain exercise on obesity, if someone is in my study, they might exercise a little bit more so that they appear to be fitter because they're in the study. And lastly, you have recall bias. And you see this a lot in questionnaires. So the same example, exercise. So if you ask patients, how much did you exercise last week? They might be selective with how they remember the past details. So you introduce recall bias. So again, blinding and masking can help with this, can help reduce observation bias. So researchers and subjects, as we said, they're influenced by what they know, by what they believe. I mean, we're humans after all, and we all have these subconscious expectations. So to reduce observation bias, you might have a trial that's not blinded, so an open label trial, and this is where observation bias is a big issue. Or you can have a single blind study. So either the researcher or subject is blinded, or a double blind where both are blinded, or even a triple blind. So the researcher is blinded, the subject is blinded, and the person processing the results is blinded. So I think ideally, a triple blind is the least prone to bias. Okay, so lastly, we're looking at, now we've decided what outcomes we're going to do, how we're going to collect them. And then the next thing is, how will we make sure that the outcomes we measure are also valid? Okay, so measuring outcomes is really looking at endpoints. Okay, so studies report results in terms of outcomes or endpoints that are measured. So ideally, endpoints should help doctors make better decisions for their patients, and they should have clinical meaning or impact, okay? And we have different types of outcomes or endpoints that we can measure. You have clinical outcomes, such as the measurement of a direct clinical outcome, like mortality or readmission. You can have surrogate outcomes. So surrogate outcomes are when you use a biomarker as a substitute for a clinical endpoint that is expected to predict a clinical benefit. For example, instead of looking at mortality, I'm going to look at CRP level as my main outcome, okay? And composite is when you use a combination of clinical events like they did in the COVID surge study, and you combine them together. So you combine mortality with the need for surgery with pulmonary complications. Why do you do that? Let's say the mortality for whatever I'm looking at is really low. So 0.1% of people die. So I would need a huge sample size to even see a difference between the groups. So I start combining all these outcomes together. And last point is you can also have secondary outpoints. So you have a primary outpoint or outcome, and then you have secondary. So there are other characteristics measured in the study to describe the impact of a treatment. And when you're looking at endpoints, you're assessing the validity and the reliability of the endpoints. So as well as specifying what are the endpoints I'm going to use, you should describe how you measure those endpoints and how you detected them. Clinical endpoints are easy. So mortality, you're either alive or dead. It's like simple. Surrogate endpoints like CRP are more prone to subjective assessments or questionnaires, and problems can arise if it's not made consistently. So we know that CRP is an inflammatory marker, but other things can raise it, and it can make it not as clean a design. So ideally, researchers should use measuring techniques and instruments that have been shown to be valid and reliable, especially if you're going to use questionnaires. You can't pick a random questionnaire or just make up a questionnaire. It's better for your research design if you use something that's been validated, okay? And endpoints must also have an appropriate follow-up. There's no point looking at mortality and measuring it for 3 days. You have to have 30-day, 60-day, 1-year follow-up, depending on what you're looking at. So what is validity and reliability, which we just mentioned? So validity is the extent to which a test measures what it's supposed to measure. This is the classic bullseye diagram you can see in all your medical textbooks. So valid is how good are you at hitting the bullseye, basically. Reliability is how consistent is that test if I keep on repeating it. So you might miss the bullseye, but at least you're reliable. You keep hitting the same points, okay? So when you're using questionnaires, you'll see that validated questionnaires, at least someone has, used specific methodology to see that the questionnaire is measuring what you intended it to. And when you give it to multiple people, you get the same results. So that's really important. So we went through the main elements of research design to consider, and now I'm going to talk to you about how you adopt a systematic approach to a critical appraisal. So when you are given a specific article, what's the next step, okay? And critical appraisal really varies by study type, okay? I really highly recommend that if you're not familiar with this, you start by using standardized checklists. And these standardized checklists, they're freely available. You can just Google them and you will have them at your disposal. So next time you have a journal club or you read a new article, you just print it and you fill in the gaps, okay? There are checklists for specific study designs. And there's also, I'll talk to you about the CASP checklist, which is one of my favorite, okay? And again, reiterate, the 3 main questions we're considering is how serious is the risk of the bias in the study? Does the design match the question? Is the methodology sound? The next question is what are the results of the study? The last question is external validity. Can I apply these study results to my patients? So checklists for specific study types, I've listed them here, okay? You can have the slides for these if you think it's useful, but those lists are useful because if you are gonna publish a study, a lot of the good journals will ask you to actually fill these checklists for your study. So if you did it from the beginning, then you're gonna check all the right boxes. So for epidemiological study, you're looking for the STROBE checklist. For diagnostic studies, the STARD. For treatments like RCT, you want the CONSORT. And I'd highly recommend if you're designing one of the studies to register your trial before you submit it for publication. For guidelines, you're looking at the AGREE instrument. And for systematic reviews and meta-analysis, you want the PRISMA. And again, you want to register it at Prospero or Cochrane when you're looking to publish it. So if you're reading an RCT and you want to do a critical appraisal, just Google CONSORT and fill in the check boxes, basically. The CASP checklist is also a freely available tool. So it's very generously available through that link. It's an excellent resource and offers multiple checklists that are available to you for multiple study types. And they also offer an online course in critical appraisal skill. So I'm just gonna go through some of the questions. If this was a live course, then we can practice some of these, but I'm just gonna give you a sense of what's in the checklist. So for an RCT, the CASP checklist starts with the question, is the design valid? So it asks, did the study have what's the PICO? How were the participants assigned to interventions? Were all the participants who entered the study accounted for at the conclusion? What's the dropout rate? Then is the methodology sounds? Was there blinding? What are the baseline characteristics between the groups, where we look at confounding? Did the groups receive the same level of care? And then what are the results? Okay, so this is where a lot of the statistics comes in, and we can talk about that in our next session. And the last question is, will the results help locally? Can I apply the results of the study to my local population? And do I have the resources to incorporate it? I'll do two more examples. So this is the CASP checklist for systematic reviews. Again, is it valid? What is the PICO? Did the authors look for the right type of papers? Do you think all the important papers were included? Did the authors exclude non-English language, for example, which would make it less comprehensive? Did the authors do enough to assess the quality of the study? If the results have been combined, is it reasonable? Again, what are the results? How precise are they? And can I apply it locally? What are the benefits and harms? Last example will be the CASP checklist for a cohort study. So first question again is always going to be, is the result valid? What's the PICO? Was the cohort recruited in an acceptable way? Was the exposure measured to minimize bias? What about the outcomes? What are the confounders? You can see that these are the same pattern, basically. Even though they're slightly different, they're pretty much the same. Again, looking at follow-up, what are the results? How precise are they? Do you believe them? Can you apply it locally? So this is the pattern. Again, internal validity, external validity. Again, what's the question? What's the design? Sampling, allocation, outcomes. How did we measure the outcomes? It all goes back to the same fundamentals. Again, you can Google this at your own leisure. There's other CASP checklists for qualitative studies, diagnostic studies, case control, economic evaluation, clinical prediction rule. Like we said, there's so many research design, but as long as you have the same fundamentals, you should just be systematic in your approach. Now, last part of our talk, how do you apply evidence-based medicine in your practice, okay? And there are 4 considerations to think about. What are the patient's values and preferences? Finding the right type of evidence for you to critically appraise. What are the resources you need? And how do you incorporate expertise and clinical judgment into what you intend to practice? So how do you incorporate patient perspectives and preferences into your decision-making, okay? So patients are varied, and even though the best evidence might suggest the treatment, your patient might not be interested in it for whatever reason. Maybe they don't want to have surgery. So a few things you can look at. One is it's good to look at tools that have subjective assessments. These are called patient-reported outcome measures, or PROMs. These are tools that are increasingly being used in studies and trials to look at the patient's perspective. And they're the outcomes that matter most to patients. So I would suggest that you either incorporate validated PROMs into your study or look for studies that look at those. And they're usually developed after extensive qualitative research and validation. Actually, in some hospitals like MGH, they have a program where they get PROMs from every single patient who walks in the door. Shared decision-making is a systematic way of incorporating patient preferences into your evidence-based practice. Several tools exist. Again, you have validated instruments, decision aids, option grids, risk calculators. So trying to incorporate these with the best evidence really gets you into the habit of practicing evidence-based medicine, which is more systematic. Next is, well, I know how to appraise research. How do I find the best research, right? Sometimes when you are researching a topic, it feels so overwhelming because I don't know how many millions of papers are published every year. It's just impossible to keep up. And like we said, it's become an essential skill. Using search engines deliberately is becoming a very important skill so that you're able to at least keep pace with the high rate of new research. Again, I'm going to keep on saying it. Structure a question using PICO and use that to guide your search terms and your filters, okay? Here, I listed resources you can use, okay? So where do you search? You have the pyramid of evidence-based resources, okay? So you have summaries and guidelines, and these are resources that summarize the evidence top level with usually actionable recommendations. This is your UpToDate, your Dynamed, your clinical evidence, the US National Guidelines Clearinghouse. So these are resources you can start off with. The second type is pre-appraised research. So these are synopses of systematic reviews, usually summarized into one page. This is going to be your ACP Journal Club, your McMaster Plus, Cochrane, etc. Third is the most common we use, which is usually sometimes you can't find what the question you're looking for in the above resources. So you use non-appraised research. So these are filtered and unfiltered studies using classical databases such as PubMed, CINAHL, Central. The last one is actually the most useful if you're starting from scratch, and I would recommend you start there, which is federated searches. So all layers of resources from the top three are filtered into one. So this is the Access and the TRIP database, which are free. So these are search engines that retrieve evidence from the above three and organizes it accordingly. So it's a great resource. And then again, once you have done your search or come up with millions of research articles, so you should filter them by, addressing the hierarchy of research, okay? So we talked about all these studies, and they're usually organized into this pyramid that you can see. So at the very bottom, you have animal lab research, then case reports and case series, then you have case controls, then cohorts, RCTs, meta-analyses, and then clinical practice guidelines should be at the top of the pyramid. And you'll see people refer to this as level 1 evidence, level 2 evidence, level 3 evidence, et cetera, et cetera, et cetera. So when you have all these research articles, I would suggest you start with your systematic reviews or RCTs, just to give you a sense of the core research that's available. But it doesn't mean you should ignore the bottom. You should still look at them. And sometimes you don't have RCTs or systematic reviews. You just have case reports, in which case this is where you should start doing research because you've identified a gap. Okay, so the third element to consider, which we touched upon, is I want to incorporate all this into practice. Do I have the resources to introduce this new intervention? Do we have the financial skills in our hospital, this training? Is there a cost to my patient? If the best thing is robotic hip replacement, what is it going to cost me and what is it going to cost the patients is the next question. And if you're not sure, you can look at articles that have done economic evaluation. So these are really great articles, and they've, increased in numbers recently. So you're looking at things like cost benefit analysis, cost utility, cost effectiveness. So these articles are really good to give you a sense of, do I have the resources to change my practice? And the last thing is, incorporating your clinical judgment, your expertise. And this is important, but I would say exercise it with caution. There in the slide, I've listed examples of what we now know as harmful practices that were once supported by expert opinion. People used to think bloodletting was great. Frontal lobotomy, actually the person who came up with frontal lobotomy got the Nobel Prize, where they used to drill a piece of metal through your skull to treat depression. So, they got the Nobel Prize, but now no one would even think of doing that. It'd be a crime. Thalidomide, bed rest for back pain. So there's all these things that, people decided to do, but they didn't do RCTs or anything. They just relied on expert opinion. So incorporate it, but incorporate with caution. Okay. So last thing I want to share with you is the best resources to get you established in this area, if you're interested to look into it further, or if you want a book with a bunch of checklists that can get you started. So entry level, I really recommend PASS Test, the Doctor's Guide to Critical Appraisal. It's really, really good. Okay. And it's really simple. It's very easy to read. There's also the BMJ's How to Read a Paper, which has a little bit more detail. And then lastly, if you want to go to the next level, the User's Guide to the Medical Literature by JAMA. It's based on a bunch of articles that were published in JAMA, and it has a second book that focuses on the statistical part. So these are resources that I highly recommend. And actually my entire talk is based on them. So there's nothing original there. And yeah, if you have any questions, happy to answer them. Thank you.
Thank you, Dr. Sara, for your time and effort. I really enjoyed this session. It was really informative and helpful, to be honest. And I'm looking forward for future sessions. As you guys know, going further, this course is going to discuss how to interpret research results, how to write a paper for publication, and lastly, how to publish that paper. And they will all be presented by Dr. Sara Lioha. And lastly, please don't forget to register and scan the QR codes for the next session. And as you can see, these are the QR codes up on the screen. The next is going to be the ABCs of Research and the Surgical Fix series, which will be given by Dr. Alexander Lee about gastroesophageal reflux disease, which is on Sunday, and the surgical debate. Thank you all for joining in, and I hope to see you all again in the next session. And thank you.
Thank you.
I think there's a question that says, could you explain prospective cohort study and p-value?
Prospective cohort study and what, sorry? And p-value?
P-value, yeah.
Okay, so a prospective cohort is, like we mentioned, you have a group of patients that you identify, and then you're interested in looking at a specific exposure. So you're looking at following these people up over time. For example, the study example we put is smoking. So I'm interested in knowing if smoking is linked to lung cancer. So I'm going to identify a group of patients. So in that study, they identified doctors, and then they looked at the doctors who smoked, the doctors who didn't smoke. Let's follow them for 20 years and see who gets lung cancer, for example. So whatever group you picked, you assign them different groups and you just follow them over time. So that's a prospective cohort. So the p-value is basically a preset probability for where, or a threshold for where you're going to decide there's going to be a statistical difference. Classically, it's set as 0.05, and it's looking at whether your null hypothesis is correct. We'll look at it in the next session for anyone that's interested in more detail. Thank you for the question.
Thank you again, Dr. Sara. And as I mentioned earlier, please don't forget to register. There's a link in the chat, and the QR codes as well are available for future ABCs of research. Thank you all.